So welcome everyone for coming to this event, which is a book talk about doing great harm by Dr. Stanley Goldfarb. I'm going to give a little longer introduction than usual, but I'll still make it brief. And then at 6:45, we're going to chat afterwards, and at 6:45, Representative Greg Murphy will join us. So let me just give you a little backstory here. So my name is Sally Satel. I'm a resident senior fellow here, and I also went to medical school and became a psychiatrist, and that's the source of my interest in this topic. So when I was in medical school, which was, gosh, in the 90s, late 80s, I should say, there was a lot of emphasis on, now I want the first slide, I only have 2 slides. First one, please, something called social determinants of health. And if anyone, for those of you who are in the sort of the medical world, I'm sure it's a familiar phrase. And it's, it's a very legitimate concept. The idea that health, in addition to our physiology, is also determined by these various psychosocial factors. I think that these are excellent topics for physicians to research. Well, they're mostly researched by public health people. They're very important. Doctors have to be aware of them. But the question is, of course, what can physicians do about them? How can we influence these other domains? And that's kind of an ongoing debate in the field. These are clearly realms that are outside of our expertise, and people disagree on how much attention physicians should pay to them. But after the murder of George Floyd in 2020, I guess I would change the slide, and I would add, no, not yet, back. I would change that slide. I'll tell you the way I would have yet a, it's interesting how the arrows go out. They really, yes, okay. If the arrows were pointing in at health status, then another arrow would be emanating from oppression, from social oppression. And that would be considered also a determinant of health. And that has really changed, has done a lot to change the way we think of factors that influence health. And so if you can get to the next slide, Ben. And this is kind of a classic manifestation of how it has kind of changed a lot of the ethos around medicine, taken us down frankly, a pretty worrisome path. I don't have to read it to you. You can see the key words, white supremacy, racism, and so on. Now, the emphasis is obviously there on identity politics, social justice, imperatives, and wokeness, anti-racist medicine. They all fit together, and if you were reading the literature or going on various websites, you would see those words. And this has really had a pervasive impact on medical training, and also how younger doctors, I think, are coming to see their profession. I think they are, not all of them, of course, but I think there's kind of a trend towards younger physicians seeing their profession as a vehicle for social justice, as if treating people were not enough, and also taking on some activities that we would consider activism, that again lie outside the realm of what we are trained to do and what our expertise is. So again, I want to say, yes, there are excellent medical programs and serious medical students everywhere. But these new trends are, I think, doing great harm, which is the title, of course, of your book. And now I will introduce you, and we'll talk about the ways in which, well, there is a question mark, but I think the answer is yes. So Dr. Stanley Goldfarb is a nephrologist and former Associate Dean of Curriculum at the University of Pennsylvania School of Medicine. In 2022, he was the author of a very interestingly titled book, Take 2 Aspirin and Call Me by My Pronouns, which was spurred, his writing of this was spurred by his concern over Penn teaching about politicized topics that were really outside of the orbit of medicine, and for being ostracized 3 years before he wrote the book by his own medical school and elsewhere for writing an op-ed with that same title and for criticizing those trends. So he founded Do No Harm, a nonprofit. He founded that in 2022, which is an organization that seeks to highlight divisive trends in medicine, such as DEI and youth-focused gender ideology. His current book is an expose of the challenges faced by our profession at a time when social justice imperatives are ubiquitous, and shows also how his organization is working to take the politics out of, or take the identity politics out of medicine. So thank you so much for being here.
Well, thank you so much.
Okay.
Can you hear me okay? Yeah, good.
So I'll just start off by saying I have three goals for our conversation, which is, one is, just to give the audience a sampling of some of the excesses that are going on. Two is, second, to talk about how it is harming the patients potentially and the profession. And three is what you guys are doing to combat some of this. So maybe I'll just start with, you want to just talk about what you consider to be some of the worst developments, the most worrisome developments in the field now?
Yeah, well, thank you again for this opportunity. I think the thing that has motivated me the most is that I feel like, there's the medical profession really thrives on trust, and trust by patients and trust by the community. And if we do something that undermines that trust, it's a very risky proposition, and it could lead to really terrible outcomes. So how are we undermining trust? Well, we've decided that the diversity, equity, and inclusion regime is something that needs to be injected into healthcare. And what that really means, what it means if we say that diversity is going to be a value that we're going to really seek in the people that become physicians, the people that train physicians, that we're sacrificing merit. And the evidence that we're sacrificing merit, I think, is quite clear in healthcare in terms of the people that are being chosen to be physicians. Now, when I say chosen, there are 55,000 students that apply for some 22,000 positions each year. So if we decide that we're going to take someone into medical school that is less qualified than someone else, that someone else is not going to get to be a doctor. And the public is going to be deprived of someone who is more qualified. And what's the evidence that that's the case? Well, the evidence that that's the case is sort of performance on achievement tests, performance as residents, trainees after they go to medical school, and now some evidence of performance as clinicians. And we can go through the details of the evidence for supporting those statements. But that's my biggest concern. My biggest concern is that we're turning out a cohort of individuals who are going to be physicians, and we're denying that opportunity to individuals who want to be physicians, who are going to be more capable physicians. And what that's going to lead to is undermining the trust of the public, because once it's clear that that's the case, people are going to wonder, I'm going into the emergency room, I'm going into cardiac surgery, I'm looking up at this individual who's going to operate on me, I'm looking up at this individual who's going to assess me. How good are they? Are they the best people available to care for me? Are they the best people available to care for my family? So I think that's what concerns me the most, is that the healthcare workforce will stop being individuals that we can trust and start being individuals that we wonder about. This turns out to be a phenomenon that we're starting to see. We hear from patients, unfortunately, we hear from patients, and we hear from Black patients, actually. And it's minority individuals who are being promoted. And we hear from these patients. We have a good colleague at Temple Medical School, Kevin Williams, who has patients. He's a practicing cardiologist, and he has patients who tell him, Black patients, because Temple is in an inner city institution, tells them, I want to make sure that I have a white physician. This is a disaster for American medicine because the trust has been started to be lost when people understand that these non-meritorious bases for being admitted to the medical school are the case. So if you ask me, that's sort of the biggest concern that I have. The rest of it is we're just going to have a healthcare system that is going to make other people wonder about whether they're being treated differently because of their race. And when Do No Harm started, the first initiative that we had was to sue the federal government. Why did we sue the federal government? Because Medicare published a rule back in, I guess, 2021, December of 2021, that within Medicare, physicians would get an extra payment if in their practices they produced some sort of protocol that was anti-racist. You saw the words anti-racist published as part of the American Medical Association. So what that was really saying was if you treat patients differently because of their race, we're going to pay you more money. And we felt that's a terrible idea. And we're a membership organization. By the way, we're up to 50,000 members now in our organization, about a third of whom are healthcare workers, of doctors, of students, and so on. So if you're a physician, and many physicians say, I care for all my patients the same. I'm not going to care for people differently because of the way they look. And we had one member who was very offended by this and was the plaintiff in the suit. And now that suit has been working its way through the courts, and in fact, now the administration and HHS has decided they're going to eliminate that rule because it's just so unfair. So that's the second part of it, that trust is going to be eroded because there'll be a sense that people are treated differently. And we certainly encountered that during COVID. We had a number of examples of states, New York, California, had algorithms for who would get scarce medications like the monoclonal antibodies. And you could be sicker, but be white than the patient in the next bed who was Black but wasn't as sick as you are, but based on the algorithm, because of their skin color, they would qualify for the medication when you wouldn't. And now this led to court suits, and actually it was never implemented because it was felt to be illegal, but there it was. And again, eroding trust because you'd come in and you'd say, well, how am I going to be treated? Am I going to be treated differently because of the way I look? So this is sort of the concerns that we have. And, now that all started a few years ago. And I think things have changed to a certain extent, but there's still a very strong notion within the healthcare world that this idea of treating people differently is one that we must pursue, and that bringing people into the healthcare system who are minorities, we must do, because that's the only way we're going to improve the healthcare of one group, one population, one part of the population, which is minority individuals. And that's ongoing now. It's something that I think is terribly wrong, and without real evidence that it's going to benefit anyone. In fact, I think we can make a good case that it's going to potentially harm the public. So that's our biggest.
Yeah, that's a big worry. Do you have
concerns.
any idea of even what Medicaid meant? How they envision what the doctor would do when the Black patient was before them, as opposed to the white patient who just left the office? I can't even fathom how this would manifest in an examining room. I don't know. Did anyone ever give you a potential example of how it could work?
No, the way it was going to work was they would just come up with something. So that something
So
might be quite rational. For example, it might be a good thing, like they'd get access to a translator if they have people who didn't speak the language. But it also was the sort of thing like the algorithm that said you were going to get more points if you were black. We were going to have a special nurse set aside to care for our black patients, for example. I mean, this sort of thing. We were going to have a case manager that was only devoted to black patients. We recently had an example in Philadelphia where it was the University of Pennsylvania, my old institution, had a program, and they worked with a local radio station, a black-owned radio station, that said that we're going to create a directory of black doctors so black patients can have black doctors. You know, it's this racialization of the healthcare system, which I think they felt, well, this is going to improve health outcomes. I mean, that, you know, again, like many times, it's not that there weren't good intentions here. The problem is how it ends up getting implemented. Make no mistake, there are great healthcare disparities that are real. I think we can talk about the social determinants of health and how that what that really means and how that's being implemented. I think, unfortunately, the way it's been interpreted, the healthcare disparities are due to, yes, if you're less educated, if you're poor, if you live in a bad neighborhood, you seem to have worse health. Somehow that's playing down on your health. We can talk about what that might mean. But since that only explains 80, maybe even 85 or 90% of healthcare disparities, what's left over must be physician bias. It must be that the healthcare system is treating people differently simply on the basis of their race because of biases, explicit biases or implicit biases, and that's what's going on. So this is an attempt to sort of get around that, but the problem is the consequences of this are treating people differently without understanding what the real basis is, without having proof that bias is the reason behind healthcare disparities. And that's the great danger, because you know, the consequences of saying we're going to have a separate protocol for these minority patients is the white patients are going to say, well, what about my separate protocol? And pretty soon we have a country that's, you know, in terrible racial distress, and maybe our country is in that now because of the focus on these issues, starting with maybe the last 10 or 15 years. And that's the concern. Yeah. That's the concern, that we're going to racialize the healthcare system even more than it's been racialized up to now, and the outcomes of that will be terrible.
Yeah. And that's one of the driving impetuses behind affirmative action, which is this notion that, these, as you said, these disparities exist. They exist in access and they exist in health status between groups. And then the implication that some have had is because there isn't enough, frankly, what's called concordance or race matching between the doctor and the patient. But this book is a great compendium. They all seem to be gone. We had some on the tables. But this book is just a great compendium of reality testing with regard to some of these myths. So for example, one very pervasive myth is the mortality discrepancy between black and white moms, and you really devote at least 4 good, pages to that. Could you?
Yeah, so that's something that I think, you know, we hear certain themes are repeated over and over again in justification for this kind of racialization of the healthcare system, and that is. And then one is that black women have a much higher maternal mortality than white women. And the only explanation for this is doctors are killing them when they get into the hospital. Serena Williams very famously had a very complicated pregnancy, almost died. But then again, my daughter-in-law, who's a wonderful person, she had a very complicated pregnancy and almost died. So that kind of thing, she's fine now, and the child is fine. Joey, he's fine. But you know, problems do happen, and anecdotes arise with someone like Serena Williams that supports the data. So what's the basis for this? Well, whenever you see there's a discrepancy in mortality, the first question you have to ask is, well, how are you measuring mortality? And it turns out that the measurement of maternal mortality is not, did you die in the hospital when you were delivering your baby? It's, did you die within 6 weeks, or in some cases 6 months, of delivering your baby? Now, if I tell you that, that suddenly opens up the possibility that things are happening outside of the healthcare system that are contributing to maternal mortality. But it is measured, the most rigorous measure is 6 weeks. Many, many countries consider it within 6 months. So now let's look at what really happens. The question is, how much of that maternal mortality is due to the healthcare system and how much of it is completely unavoidable? So anybody that goes home and is shot, that's an unavoidable mortality. But unfortunately, in the Black community, there's more violence. You know, whether I don't think that's in great dispute. What it's due to, the poverty and so on, is another question. But so any woman who dies from a non-avoidable death really shouldn't be looked upon as the basis for the deficiency in the healthcare system. So about 50% of that mortality is due to unavoidable, from the point of view of the healthcare system, factors. 50% involves the healthcare system itself. And then the question is, well, how much of it is due to patient factors? So it turns out that one of the big factors that leads to increased maternal mortality is severe hypertension, the complications of, it's called eclampsia. It's a condition in pregnancy where there's very high blood pressure. There can be complications in blood clotting. It can really be a catastrophic event for a woman. The risk factors for that is hypertension in pregnancy. Hypertension in pregnancy can be avoided if women, as soon as they're pregnant, come in for evaluation and treatment of their hypertension. It turns out that Black women come in for first trimester screening and care at about 50% of the rate of white women. So if they have hypertension and they come in the second trimester, they're going to be at greater risk of having severe hypertension that's going to be much harder to control. They're going to have many more complications associated with that pregnancy. That represents about 50% of the remaining portions of pregnancy. And then we're left with a small number that are due to physician error. Certainly happens, but again, that happens across the board. And we have a small portion that's actually due to genetic factors. Part of the healthcare disparities that Black people suffer from in this country is a factor that has to do with their origin. The enslaved people were taken from West Africa. There are certain conditions in West Africa, certain genetic characteristics of people living in West Africa, coming from West Africa, because of certain infectious diseases in West Africa. African sleeping sickness is a big problem in West Africa. There's a gene mutation that Black people grew up over many, many eons of exposure to this infection that allows them to survive that infection. That genetic mutation, or gene variant, if you will, if you take that gene and then put it into experimental animals, they get kidney disease, and the animals have more hypertension. So this is a genetic characteristics that something like 20% of African Americans have a double dose of this gene variant. It makes them at great risk of having hypertension in pregnancy, of having preeclampsia, and having a complicated pregnancy. So when you put all this together, you're left with a pretty small piece of the story that's due to complications associated with delivering the baby in the hospital. What has this led to? This has led to a sense by Black women that they shouldn't deliver their babies in the hospital, that they should deliver it at home because they're going to be harmed if they come in the hospital. And that's just totally wrong and not true. And the complications, many of them are unavoidable, and the ones that are avoidable often have a patient characteristic associated with them, not seeking health care at an appropriate time, or sometimes not reporting symptoms after the delivery associated with a complication like pulmonary emboli. Yeah. So when you sort it all out, there really is no good evidence that this is a problem of the way Black women are being treated in the hospital. It's a problem of access by them to the healthcare system, access of the healthcare system to them as well. And the solution is not to send the physician who's caring for these pregnant women to implicit bias training, yet that's what most institutions have taken on as the solution. And when you've seen institutions that have improved maternal outcomes. What they've done is they've changed their ways they handle all of their patients. They have teams, for example, if there's a rapid hemorrhage associated with delivering a baby, they have teams now that are ready to handle such a complication. They have laboratory facilities that are ready to provide the blood that these people need as an acute transfusion. And that's how they've reduced mortality. They haven't sent the OBGYN doctor to implicit bias training. They've had a medical system in place that's going to prevent the complication.
Yeah, and some of those hospitals, that was one factor you wrote about in the book, but didn't mention that many Black women go to poor performing hospitals,
Yes.
which are in minority neighborhoods. So, and when there's a brilliant study you mentioned that when white women go to those hospitals, they have more complications than they would at and when Black women go to a majority white hospital, they have fewer complications. So, and the solution is the same: improve the care.
Improve the care.
Yeah. Well, speaking of these kind, disparities, I just think it's worth lingering on a little bit more because they really are they drive so much. As I said, they drive affirmative action. They drive, frankly, the way I think we are. Like, for example, there's a major test you take after your first year of residency, the U.S. MLE, U.S. Medical Licensing Exam. Mm-hmm. That's now pass-fail. And one of the rationales for that, according to the organization that administers that test, is because minority students perform less well. Yeah. There are other, and the other thing you show in the book, this is so important, is, it's always been a debate in medical schools. I was on an admissions committee, you were, I'm sure, is, what makes a good doctor? And there are certainly factors involved, personality and temperament and conscientiousness, the latter being, I think, enormously important. But there's also, some basic, kind of intelligence for sure. And to the extent that, that's being downplayed, is a very, very big problem. And there are some, I hate to say it, but some pretty horrible stories in here, or horror stories, I should say, of medical schools that are really doing just that.
Yeah, actually, I got canceled over this issue. One of the several times that's happened. But I'll tell you what I did, which I talk about in the book. So a study came out of internal medicine residents at 6 institutions, great institutions: Harvard, University of Virginia, University of Chicago, Emory, a couple of others, asking the question, how well were the minority trainees performing as residents in internal medicine residency programs? And it turns out, as a group, they were performing less well. Over all these institutions, over a few years, over faculty assessments. Most of that it was done by faculty assessments. Just how well is this person I'm working with, how well are they doing caring for their patients? And they were statistically significantly less effective based on their faculty assessments in terms of their medical knowledge, their professionalism, their preparation for independent practice. So I wrote a tweet. And my advice to everybody is, don't write a tweet in response to anything. Go home, think about it, then write something the next day maybe. But I read this article. It was published in Academic Medicine, the journal of the American Association of Medical Colleges. This is the trade journal. It's the organization that actually is the parent organization of the accrediting body in medicine. And so it's legitimate article. My tweet, and as I read the article, I said, well, they're going to talk about how they might have some to remedy the situation. The answer was they need to assess people differently. They need to train the faculty not to be racist, and they need to make the institution more welcoming of these trainees. So my tweet was, here's the study, and I gave the reference to it, the link to it. 3 explanations are offered. Might it be that they weren't so good at being residents? Because the 3 explanations were the faculty's racist, the school, the institution is racist, or the students are not being welcomed there for some reason. The tool that they're using is racist. And, and that just tells you, there it is. This is the way it's being perceived, that in fact, we don't need, they're good enough, they're passing their licensure exam, they're good enough to care for people. Licensure exams are minimal competency exams, but this is the sense of how we're assessing these individuals with exams that turn out to predict a lot about how they're going to function as physicians, not surprisingly. I think anybody who went to school with people and you knew the ones who were the best students in the grade really were smart. That's why they were the best students. It was not a mystery how they got there. But this was being viewed as being, the problem was the fault of this institution, the fault of the assessors. The problem wasn't, they weren't just doing well. And there's another large study of emergency medicine residents with the exact same results. I don't know why they did these studies. I mean, it's looking for trouble, but they were looking for trouble, I guess, and the studies were published, and yet nobody even thought, what are we going to do to improve the quality of these trainees? The answer has been, no, we're going to take them in. It's good enough because racial concordance, having Black patients that have Black doctors is such an important initiative that we need to pursue that no matter what.
Mm-hmm. And you mentioned, again, as part of this whole constellation, the push towards what's called health equity, which of course on its surface sounds great, but some of the efforts are, I think, really would be contraindicated in treating patients. And I work with, I'm an addiction psychiatrist, so that's my population. And one example you give here, which I'm going to ask you to describe, is the one at Mass General. What did Mass General Brigham? They seem to have merged, but anyway, Mass General was involved where minority women who were pregnant were tested more often. Their urine screens for drugs were tested more often than their white counterparts. Well, again, unfortunately, the reflexive conclusion is that this is powered by racism. And there are ways to, there really are ways you could find out whether, I'll leave the word racism, that is such an unscientific and unmedical word, but it appears now in medical journals all the time. But there are kind of studies you could do. The data would seem to be readily available with chart reviews, whether there has been some discrepancy. Is it possible that one group of women who appear with more worrisome indicators, like they haven't kept their prenatal appointments, they maybe have track marks, they have other signs of neglect, and compare them, maybe there is some discrepancy, and maybe we do have to think about at least the groups being treated differently. But they didn't do that. They just did what?
Yeah, they just decided to do away with the testing, which is
change the threshold.
Yeah, truly insane, because the issue is you want to protect the children who might be the children of women who are drug addicts or might go into withdrawal. It's the same mentality as when you have more. And I know I'm straying out of my lane here, but when you have more violence in the classroom, and it turns out that more Black kids are put into some sort of a special program or sanctioned somehow, that represents sort of a bias against them as opposed to a reaction to the true situation. There are many examples of like this in medicine. There is less frequently Black patients get kidney transplants. Now, you have to understand, to get a kidney transplant, first of all, it's a great commitment on the patient's part, a huge commitment on the patient's part. And a physician would be derelict if they decided they were going to give a patient a kidney transplant in whom there really was evidence that they weren't going to be able to follow the regimen. It would be terrible, because you'd be wasting a really scarce resource that another patient might benefit from. Because if they stop taking their medications, if they don't show up to their visits, they're going to lose their kidney. It's going to be rejected by the body, and that's going to be a terribly wasteful situation. if you have a patient that hasn't taken their medication for the last 6 months and their hypertension is out of control and they've gotten kidney failure, that's not a good candidate for a kidney transplant. That patient is going to be someone, if they get a kidney transplant, they have to take their medication every day at the same time and not take any other medications that might interfere, be on a diet that wouldn't interfere with their anti-rejection medicines. It's a huge burden. You have to have a patient that's really going to be able to adhere to such a regimen before you recommend them. So if a doctor says that patient, I think, is going to be a terrible candidate, that's not bias, that's making a good medical judgment. And unfortunately, patients who have those poor social determinants of health characteristics are poor, are uneducated, live in a violent neighborhood, have a history of not accessing the healthcare system. They are really poor candidates for that treatment. The answer is not to send the doctor to bias training. The answer is to try to create educational programs that give patients insight to understand why they need to pursue a different approach to their illness. And that's just...
And we're perfectly capable of advising politicians and health authorities about what would help our patients, but not getting into those activities ourselves. We can do them on our own time, but we're not experts in housing. We're not experts in redistributing wealth or any of those things.
Yeah.
And yet, if you read medical journals, a lot of editorials really encourage that. It's, again, as you say, all well-meaning, but really we dilute our time we spend with people. We, as you say, we threaten the trust because patients wonder, well, gee, these are often politicized issues or political issues, and if the doctor seems to be, getting into these activities outside of, or I should say even inside of work, then you want your doctor to think of nothing but you when you're in that room, nothing.
Yeah, and of course, the other thing is, a lot of these issues are dealt with by social workers. Social workers go to school
them to social work.
for years to learn how to handle this. I was a kidney doctor. We had to have a social worker associated with our end-stage kidney disease program because there were so many social issues associated with our patients. They were wonderful. They knew how to access insurance schemes. They knew how to access drugs. They knew how to access transportation. That's what they did. And yet, there was an article in the New England Journal saying that physicians need to learn to be able to provide all these services. And you ask, what are they talking? It's insane, and it's just wasting a resource that we really have.
I wasn't thinking of that as much, and I agree with you. It's just they want them to change. They want us to change the system. It's just too big an ask. It's not to say that the system doesn't need to undergo alteration, but that's...
Dr. Murphy's here too.
Yeah, that's what he's doing there. So we have 10 more minutes before Dr. Murphy comes up. And so about the last quarter of the book is on trans issues. Do you want to say a word about that? And then...
Yeah, I do. So, the thing that motivated me to start was this issue about the way medical school curricula were going and the whole question of this diversity initiative in medical education and care. And when we started Do No Harm, in order for an organization like that to be successful, you need individuals, philanthropic individuals who are willing to support our work. That's where we get our funding from. And when we went to speak to these individuals who have expressed interest about healthcare and how these kinds of identity politics are acting in healthcare, one of the things they asked us, well, what about the transgender story with children? And I tell you the truth, I really was not that familiar with what was going on. We're going back now, 4 or 5 years. And, even at Penn, as running the curriculum, I had a day devoted to transgender and gay health because I thought the students needed to learn about these things. It was important. If they're going to see patients, they needed to understand these issues. But I really didn't understand what was happening with children. I didn't care for children. I care for them, but I didn't take care of children. I love children. My grandkids are just running around saying, what did Granddad just say? And so we started to look into this, and it became clear that this was just a terrible problem that was going on. And I must say, in the DEI space, if you will, calling it a space, there really isn't another organization, I think, that's quite had the impact or the activity that we've had. The gender area, there are a lot of people that are concerned about it, often driven by mothers whose children have gone through it and have just been so distressed by sort of losing their child, is the way many of them describe it. So we started to look into it, and it became clear that this was another kind of identity issue. What was happening is these children were showing up with saying, I'm in the wrong body, I need to change. And people were saying, yes, you belong in that identity. You belong in the trans identity. You need to be treated immediately with drugs. You needed to be treated maybe with surgeries. You needed to stop your puberty. You needed to take these hormones, and you're going to take them for the rest of your life. And this was it just seemed crazy. And it turns out it is crazy to do it to children. Now, our organization has made a very sharp demarcation about 18-year-olds or 19-year-olds, depending on the laws of a particular state. We feel like adults are out of our ken. And we think the issue with children is that if someone's going to make such a decision, it certainly should be a decision that should be informed. And children can't possibly, who are 12, 13, 14 years old, decide on this. I think anybody who has children or even knows children, they change their minds. You have a 3-year-old says, I'm a cat. They don't understand the implications of this, and yet they were putting through protocols by physicians. And this has been just an explosion that's happened in the United States. So we've decided to take on this issue in a way that I think is somewhat different from other organizations. Mostly their job has been to inform the public, inform groups like this, inform legislatures. We decided, and Christina Rasmussen is sitting in the back of the room. She's our executive director, and she's just a dynamo. I can't say enough good things about her and the way she works and what she's accomplished. And her push has been, we've got to have laws that save these kids. It's unfortunate that we need the government to intervene in this way in the practice of medicine. The Supreme Court has now said that it's legitimate for the government in Tennessee, the Scarametti versus the United States case, to intervene in this way because the evidence is that these children are almost certainly being harmed. That wasn't what the Supreme Court decided in their case, but that was the consequences of it, or that it's perfectly legitimate and constitutional for states to pass laws that prevent these children from going through these procedures. And the evidence has now been published in, I think there are 19 systematic reviews of the evidence that whether going through these treatments of getting hormones, getting puberty blockers, and even getting surgeries help these children. There are 19 systematic reviews done throughout the world. Multiple ones done in this country have shown that there is no good evidence that these children are benefited, and there's lots of evidence that they're harmed. And so we've taken that on as an important issue, and again, our efforts have been mostly in trying to support legislation around the country that has prevented children in many states, I think it's 27 states now, from being treated this way. We believe they need treatment. Their treatment is psychological treatment. That's what they need. And people need to understand what the basis for some child showing up one day and saying, I'm in the wrong body, particularly when it turns out to be a child that never expressed this their whole lives. Typically, they're girls, young girls, beginning to go through puberty. The historical experience with this very rare condition is that with boys who would like to dress up with dresses from the earliest moments that they were aware of these things, and yet suddenly we had an explosion in the frequency of young girls talking about the need for this kind of change, talking about the need for taking large doses of testosterone. And it's quite clear that this is sort of something that was a trend, that actually the trend may even be reversing now, and something that it was really important for us to intervene in. So that's why that became a second mission for us.
Actually stole my thunder. I was going to say there is some good news. Jean Twenge and Eric Kaufman have published data showing that trans identity among kids is going down, and her data are even more narrow, so it's more compelling and really gives so much weight to the social contagion hypothesis. So what I'm going to do now, who's a representative, I'm going to introduce you. Come up. This Representative Murphy, and you can, if you'd like the podium, for 10 to 15 minutes, and then when you're finished.
So good to see you.
Thank you.
Oh, nice to meet you. Hey. So when he's finished, then we have Q&A with both of you, if that's okay. So let me give you a brief introduction.
Okay.
Okay?
I'm me.
All right. Representative Murphy is serving his 4th term in Congress, representing the North Carolina's 3rd Congressional District, serves on the House Ways and Means Committee, and co-chairs the House GOP Doctors Caucus. He is the only practicing surgeon in Congress today. So if there's an emergency appendectomy, we're in good.
That's
okay.
right.
And if there's a heart attack, we're also in good shape. And if there's a psychotic break, that's my territory.
Which is common in DC.
Just want to mention that the reason you're here is because you, well, in addition to being a physician, which is key, but you also sponsored the EDUCATE Act, which is a brilliant acronym that I won't spell out, but that would block federal funding for medical schools and accrediting institutions that force, the word is force, students to affirm ideological beliefs and prioritize DEI. So thank you so much.
Great. Thank you all very much, and thank you. I will tell you, we have a true rock star. Dr. Goldfarb has been one of my true mentors in doing this, because he's put his literally job, profession, et cetera, on the line, kind of doing the same thing here, to do what's right, So anyway, thank you all. Welcome. I will tell you just a little bit about myself. I practice in Greenville, North Carolina, which is a very poor area of eastern North Carolina. I've done it for 35 years. I've also traveled abroad. I actually, when I was 20 years old, went and worked in a leprosy hospital in the northeast corner of India, and I've traveled throughout East Africa, through Central America, Haiti, a lot of other countries, taking care of people, as I do in eastern North Carolina, that don't look like I do. And the inference and the accusation that because I'm a white male that I'm a racist and I won't take care of somebody that doesn't look like me, frankly, pisses me off. And that's what we're seeing from so many medical schools and so many institutions that say just because you don't look like somebody means you're going to take different care of them. In fact, now, since I practice and mostly see Medicaid patients because I can't take care of, I can't get paid, most of the people I see don't look like I do. They don't. And frankly, as I said, it irritates and frankly, it pisses me off. I'm a surgeon. I'll talk that way. Sorry about that.
Right.
It's just that the liberals in medicine, which have now taken over, accuse people of that. And I will share a little story. I had surgery last year. I had something called a pituitary macroadenoma, which was a little tumor in the middle of my brain. And when you went to go see a surgeon, I did not give a damn what that person looked like, what they believed. I didn't care if they had purple hair and 3 earrings or whatever like that. I cared about the job that they did. Why? Because I was the patient. And that's what physicians should care about, is the patient in front of them, not their own beliefs. And sadly enough, we have activists in hierarchy in medical education and throughout other education. This all started in the undergraduate world, and I was on a college board at the time where every third word was diversity, except thought, of course. And it's permeated and polluted now medical education, which is literally probably the most dangerous place for it to pollute. You know, you don't want a pilot, the same thing. You don't want a bridge builder, the same thing. But with the rapidity and the number of individuals and patients that you see, the last thing that we need is activism in medicine. We need people to take care of people themselves. A couple of years ago, the Supreme Court ruled in Students for Fair Admissions versus Harvard that racially discriminatory admissions violated the Equal Protection Clause under the 14th Amendment. Very, very clear. You're not supposed to do this. But sadly enough, we still have pillars in medicine very loudly that still espouse that DEI should take prominence over competence. And I will tell you, somehow, this is kind of an ironic thing. I'm the Republican caucus co-chair of the American Medical Colleges. But I've been at war with them because they have embraced this idea, specifically their president, who said after this decision, there are ways that we can do this as long as we don't explicitly use race, but make no mistake, we will go forward. We will diversify the medical school classes. Diverse teens just make better decisions. What an asinine thing to say. Smart people make better decisions. Hardworking people make better decisions. And that he followed and said they make better decisions than homogeneous teens. What an absolutely anti-clinical statement. You know, it was also said to me that studies show that a physician of a certain race will care better for patients of that same race. The person who did those studies absolutely, and this has been now proven, left off certain data. And at the time this was actually spoken to me, they were actually recanting this. The AAMC was actually recanting this theory that, hey, that one particular race takes care of their same race better. They were recanting it, but still proposing it that this was the right way to do things. It's absolutely law. It's absolutely ridiculous. Now, sadly enough, we still have medical students and medical schools skirting this entire law, getting around it somehow. We have activist professors that are pushing their own liberal agenda on medical students. And if you guys know any type of environment, a medical student always do what they say because they want to do the best thing, they want to do the best grade. Generally, they're the most motivated individuals. And in residency, it's even more of a different authoritarian regime because doing well means a lot about that next step. But when you have activist professors and making you toe the line, and then medical schools talking about fealty oaths, it changes the entire dynamic. Instead of being academically excellent, it's more that what am I going to do, which oftentimes happens now still in undergraduate campuses. What am I going to do to please the professor? So one, I get a good assignment, and two, I get a good grade. Grades matter in medical school, and as we were just talking about a few minutes ago, now it's gone to pass-fail. Absolutely asinine. Medicine should be about the sharpest, smartest, most motivated individuals to take care of your child or your grandmother at 2 a.m. in the morning, not playing DEI politics with medicine. And you know, I take this absolutely personally because all of us in here, unless you're really graced by the grace of God, will at some point be a patient. And you're in such a position of a patient, you walk into a doctor's office and it's a place of fear. You're afraid. You want the doctor to be nice to you. You want these other things. But what do you want? Most of all, you want a competent physician. But now, because of DEI politics and certain things like at the AAMC, you're not teaching competence, you're teaching politics, which is anathema to what has always been and what always should be. I would submit that the patients that I take care of, the Hispanics I take care of that have to use a translator, the African Americans that I take care of that have to use a translator, other nationalities that I take care of, don't give a damn about the color of my skin. They care about my competence. And it is absolutely ridiculous that even in today's world, despite what has been put forth by the Supreme Court, that this nonsense is still continuing. It is still continuing. You know, a few years ago, it happened at one university in North Carolina where a medical student, or resident rather, was wearing her pronouns on her shirt. And one patient didn't like that and kind of joked about that. And what did that student do? She put out on Twitter, yeah, I had to stick them twice. Now, was that delight in the second one? I guess I can't make that comment. A big uproar about that. Things went quiet, but that student still graduated. If I had been dean, student would have been gone, period. That person did not deserve to carry the MD behind their name. But that type of stuff gets pushed under the rug. I will tell you, you know, Do No Harm has done such great work with medical schools, but really what also hurts are the accrediting bodies for medical schools, because they get to go in, and this is where the medical schools hide behind this. They're saying, well, the accrediting bodies tell us that we have to do this. ACGME has embraced this horribly degrading, divisive, discriminatory policy of DEI. They say now, a couple months ago, they're going to reverse this. I'm sorry, I don't believe a damn thing they say. I don't believe a damn thing they say, because they still have the same people in positions of power who still profess these ideas, and they will pay lip service to this nonsense until maybe another administration comes in, and just like a flower that's gone down for a little while, it'll rear its ugly head. So I don't believe them at all until they do an absolute flush of their leadership. Same thing over at the AAMC. Until they do an absolute flush of their leadership, nothing will change, because they believe in this abusive, I think, philosophy and theology, literally, of that what matters are mutable factors such as the color of your skin or which sex you are, or all this other nonsense really makes you a good doctor. No, what makes you a good doctor is that you're caring and that you're smart and you care about the patient first, period, point blank. I will tell you, I put my name on the line on the Educate Act and took some heat from it, but that's okay. That's okay, because why? Because it's the right thing to do for patients, no matter what you look like, no matter what you look like. Rewriting academic standards, ejecting identity politics into medicine is absolutely, and I believe morally wrong. They have students now that have to sign still loyalty oaths at some institutions. What is it, at the University of Wisconsin, I believe it was, you have to admit that, University of Minnesota, they pledged to be actively anti-racist. So that's an implication that everybody is, by definition, racist. I love the left. They just love to call words, you're racist, misogynist, you name it, because when they can't have a good argument, they just call you a name. It's critical. We reintroduced it this year. I'm happy to do it with Senators John Kennedy and Eric Schmidt over in the House, and Congressman Burgess Owens, who is a black gentleman from Utah. He despises the whole DEI initiative because it basically is saying that your worth is not from what you believe it is, what you work for, but rather literally an immutable characteristic such as the color of your skin. That's absolutely antithetical to what Martin Luther King said. Absolutely antithetical. But somehow that's gone by the wayside. So I will just give you a few notions of this, and then we're happy to answer questions, because I will talk one thing real quickly just about the trans issue. I'm a urologist, so sometimes we have to deal with this disorder. I would actually submit, Dr. Goldfarb, that we ought to push it to 25, because the prefrontal cortex is not fully developed in cognition until that age. But I'm sure I'd catch a lot of heat for that. But until 25, people really don't know what they're doing. Yeah. They really don't know how to make these decisions. And good Lord, the wackos over in California, all in Hollywood, you have seen an explosion of Hollywood celebrities, their kids, embracing this. It's parental abuse. All these kids go through it. I was, back in my days of taking psychology, my remembrance is that at 5 or 6, most kids go through this questioning period. And then all of 99% revert back to what the good Lord intended us to do. It is a psychological problem. It is not a surgical disease. It is a parental abuse and societal abuse that ruins these kids' lives. And, look, I'm not in that body. I don't have that issue that I don't feel like I'm in the wrong body. I feel sad and sorrowful for the folks who are battling with that. You don't fix that with surgery. They did these studies at Hopkins in the 60s, in the late 60s, and they found they were wrong then. Why we're reinventing the wheel because of some liberal push to be nice is ridiculous. It's absurd. All the Western European countries have abandoned it. The health service in Britain has. Sweden has abandoned it. Why we're still doing some of this stuff here in the United States? It's malpractice. Point blank, it's malpractice if you're pushing this stuff. So lots of different things. And I'll kind of end with this. And this is what you get when you push DEI and admissions process. UCLA. Jennifer Lucera, who's the Dean of Admissions, embraced all of this in 2020. The UCLA, last year, a fourth of the medical students, failed 3 or more shelf examinations, forcing some students to repeat classes and persuading others to postpone step 2 of license examination. What does that tell you if 1/4 of your medical school fails these things? Previous to that, 50% at UCLA failed some of the standardized tests on emergency medicine, family medicine, internal medicine, pediatrics. Half of the class fails. When I was in medical school, maybe, Stan, I don't know, 2, 3, 4% of people failed. You just didn't get into medical school unless you really should be deserved to be in medical school. But since we've gone away from requiring things like SAT undergrad or not looking at grades and some of these other things, we are doing an absolute disservice, again, to why this all matters to the patient, And shame on those people who are still pushing this ridiculous discriminatory philosophy and theology, because they are causing harm. Thank you. With that, I'll put some questions.
Okay. Sit there.
Okay.
Can you share? We didn't have a Q&A before, so can you
I can share.
share the Q&A? Great. And please.
You want another chair? Or I can sit here?
Yeah, no, sit there.
Okay,
I'll
all
sit
right.
here.
You can see why he got elected.
Look, I didn't do this on purpose.
No.
No.
Okay. So
Get in politics.
now we're ready for Q&A, but I can't see. Okay, well, Andrew?
This one, somebody.
Yeah, and then I'll come to you.
So one of the most concerning issues is discrimination in giving out medical care. What's the state of that issue currently? How often is it happening? How's it happening? How's it being responded to?
Just to clarify, exactly what you mean by discrimination.
You mentioned during COVID, there was the antibodies that they were planning to give out using a race-based metric. To what extent are clinics, hospitals, or other places practicing medicine in that way now? Is it gone? Did we win on that issue, or is it still persisting in some form?
I can't answer it in a global sense. Our organization is an organization that gets a lot of tips from members. And what we hear about particularly is this continued racialism in the way people are chosen into medical school, the admissions process, in scholarships, in support services for students, and so on. I think the question about differential care for patients, I think, has really been, that initiative has fallen by the wayside. It was challenged in the courts a lot. Having said that, if you looked at the New England Journal last week, there was a whole series in the perspective section, which is sort of, it's scientific, but it's more an opinion piece. They talked about all the initiatives that are underway in order to get rid of health inequity. In that sense, they continue to look at programs that will change the way patient care is administered. As a nephrologist in kidney disease, this continues to be a real issue where there's been manipulation of all sorts of data in order to try to get more Black patients to have kidney transplants, when the problem has really been some of the things I talked about, the sense that often Black patients don't want kidney transplants, they do well on dialysis, and yet it's been blamed on the healthcare system. So I think there are areas in which this issue has come up, but the kind of overt thing that COVID justified, these emergency procedures and really rather draconian kinds of efforts, I think that's fallen by the wayside, fortunately.
If it's okay, I'll follow up with that. I think it's and also there may be, also what you might be asking is access. Access to care. And I live in a world where there's a very high African-American population, as I said, a large Hispanic population. Oftentimes these folks are on Medicaid. Medicaid doesn't pay the bills, so there are certain folks that only take so many Medicaid patients. It's not because their skin color, it's because of the, quote, insurance that they have doesn't pay the bill. Now, we have a medical school that doesn't turn anybody away. Our hospital doesn't turn anybody away. Emergency rooms don't turn anybody away. But I think it is an access issue, but it's also a cultural issue in a way that some folks, I'll pick prostate cancer because this is what I've dealt with for 35 years. I used to go out and talk in a lot of African-American churches saying, please come get screened, please come get screened. There was also a cultural issue that they do want to do that. And this is really hard because African-Americans have a higher stage disease, they have a higher lethality of disease, a higher mortality from disease, but that doesn't make me a racist because of that. It doesn't make society a racist because of these immutable genetic characteristics of a disease. But that's what the left wants to say, wants to paint that. I will say, I'm going to go back to one other thing we talked about as far as with medical education. And I talked to a group the other day just about education itself. Where does education start? Education starts in the home. And in 1965 began the destruction of the human family unit. And we have so many kids, especially minorities, that grow up in single-parent homes that don't have good educational examples to go after, and then all of a sudden they're behind the 8 ball. So are we just trying to jump that and forget that education starts at the home and then just start it at medical school? You're doing a grand disservice to patients. So just getting back to I'm sorry, that was a little diatribe. Getting back to the access issue, it is an access issue. It absolutely is an access issue, but it doesn't mean people are not taking care of somebody literally because of the way they look.
And just to follow up on that, give you one example, which is really the most, I think, a striking one. It's about uterine cancer. Uterine cancer is a terrible disease. White women show up after their first symptom, which is usually abnormal bleeding, about 3 months after their first incidence. Black women show up about 8 months after their first incident. And again, so access is a two-way street. Access is not only providing the services, but it's also accessing the services. And, when you look at people talk about the underserved areas in the United States, the medically underserved areas in the United States is not a function of whether there's a physician nearby. West Philadelphia is considered an underserved medical area in the United States. West Philadelphia has a hospital there that has something like 3,000 doctors on staff. Underserved medical areas, according to the US government, it's a function of the ratio of primary care to the population, the aging of the population, and the socioeconomic conditions of the population. So access is possible. That's not to say access is easy. I think any of you that try to get a health care appointment know sometimes it can be a real problem. It can take time to get to the dermatologist. That is an access problem. And dealing with that issue is the way we need to focus on it, rather than, again, the answer being, let's send the physicians off to implicit bias training, let's hire a DEI officer, rather than let's have a mobile van that goes out into the community to provide prostate screenings or provide mammograms. Organizations that spend their money on that, I think, are justifying the tax-exempt status of not-for-profit hospitals. I was on a hearing that Dr. Representative Murphy's committee, the Ways and Means Committee, held about this issue, and hospitals need to do a better job of making access possible, but patients need to access the system, and education is the way that patients need to learn how to access the system, and that's something that really needs to be done.
Okay, ma'am? Yeah, you.
So I have a friend, we live in Maryland, I have a friend who is a psychiatrist there, and she's thinking about leaving the profession because of what she's forced to go through to keep her license. The trainings, the loyalty statements, and she can't treat patients the way she wants to treat patients because she could lose her license. So what can we do about that?
Yeah, Maryland's interesting because they have in order to get your license renewed, you have to take a course in implicit bias training. And implicit bias says that we all have these biases and they're governing our actions. It's sort of denying free will. And to me, what really mattered, not what was hidden inside my brain, but how did I act? What did I actually do? And it turns out the way that it's measured, implicit bias, is a test that is completely unreliable. It's not reproducible. And yet Michigan, Oregon, and now Maryland is requiring this. Now, I should tell you, Do No Harm in Michigan and in Oregon as well put forward a course on implicit bias training where we said just what I said. Implicit bias is not the issue. The issue is how you act. That implicit bias examinations, these tests are unreliable. and that the answer to all this is to make sure patients have good access to health care, that they access the system and the system makes it as easy as possible for them to get care, and that implicit bias is not the reason for healthcare disparities. You know, those social determinants of health, if you look at them, to support what Representative Murphy just said, is there's nothing on there about patient factors. There's nothing on there about patient actions. There's nothing on there about patients seeking health care at an appropriate time. It's all about what's going on around them. And I think what's going on around them may influence their decision making, but the answer to that is to fix their decision making through education.
I just wanted to pipe up and say that you said this, but this is such a well-replicated finding that the IAT has no predictive value as to how people behave. And it's just shocking that they are continuing to put this forth as if it's a valid
You can
and
take the
reliable
test. You can go online
Yeah.
and take it. It was produced at Harvard. You'll see how ridiculous it is. It's how quickly you press a button on your computer when you see an image and a word up there. So a face appears and the word good, and if you click it more quickly, if it's a white face compared to a black face, that means that you're biased against the black people.
But only
It's
in the
all
morning.
ridiculous.
You can retake the test
And then you
the next
retake
day,
it 2 weeks later.
and it's different.
And people actually say, oh, I wonder if the black person is being discriminated against. They have that thought, and that slows down their response. It's all absurd.
Lady in the back? Oh, that's you, Christina. Christina
Congressman Murphy, you were a trailblazer in calling this out for what it really is. At a time when it wasn't necessarily so popular to say these things, you were really courageous.
Still not popular.
Since then, we have a new president, President Trump, who earlier this year said, hey, maybe we should have some market competition for these monopolistic accreditors who are pushing bad things. So my question for you is, how can this Congress, who's doing really great things, work with this president to get some big, lasting wins in place?
Yeah, so I think this is, the Supreme Court said it, and we have places that are trying to skirt it. But I think this administration, and as you know, HHS has said, we're not tolerating this. We don't get funding. This is where you can't make people change behaviors just by saying do it. You have to, I'm sorry. You have to do it via funding. You have to pull people's funding. And that is the critical part. I won't talk about one particular school, but I was on a Zoom call with their dean and their associate dean and their academic dean at the medical school, and they had put forth the faculty 48 new DEI initiatives. And I went berserk on them. And they said, well, we're only implementing 4. And I said, well, that's a lie, because I'm looking at a piece of paper that you've pushed things further. Yank their funding. And I'm okay with that, because that's the way you change behavior. And to push all of this nonsense, this is like the emperor's new clothes. This is the greatest peer pressure event since the Spanish Inquisition. Because if you don't do it, you're a racist, you're a misogynist, you're this, you're that, and the other stuff. And you talk to people in faculty, because the Trump administration has come through, and they're quietly saying, thank God, you guys came in and just pulled this out, because this is totally distracting me from my clinical duties, my research duties, all the nonsense that was funded at NIH because of diversity studies and all this other nonsense. Thank God we can actually get back to real science and real clinical medicine.
So, Dr. Murphy, why do you think that physicians, basically, if it's hard to stick your head above the rooftop, as you did, Stan, but if doctors came together, especially more senior ones, because I imagine they're the ones who find this most problematic, I think there's a generational gradient and acceptability to this, but why don't they kind of bind together and resist?
Well, because I'll give you one example. I went to go speak to a group of physicians, and I'm a leading voice for physicians because of payment and all this other stuff, and probably one of the loudest voices on that. But I went to go talk to them in the midst of all this with the Educate Act, and I don't know, there were probably 200, 300 docs in there. I got booed by a whole bunch of them because I stood up and said that this DEI stuff is wrong. So, putting 10 doctors in a room, you're going to get 10 different opinions about things. And so this is what's so hard. When you have accrediting agencies pushing this down, medical schools, faculties, et cetera, pushing this down, admissions that only bring people in that think like this or think like this, it's very, very hard. But I will tell you, I would say the infinite majority of physicians, when they're taking care of the patients, think about the disease process and think about how can I take care of the patient. They don't think about any of this nonsense. And shame on the ones who think about activism as their goal, not clinical medicine.
Any last words, Dan, then?
Yeah, when I was a kidney doctor, as I said, 30% of the patients on dialysis are Black because of this genetic mutation that I was talking about earlier. And the very notion that I would do something to harm those patients, to lead to worse outcomes, and is so, it's so enraging. And my colleagues talk about this. Most of those patients were like family. I'd see them 3 times a week in the hospital because they get the dialysis treatments 3 times a week. You see someone 3 times a week for a couple of years, that's someone that you're pretty close with. And the very notion that I would treat that patient differently because of the way they look is just so painful and so wrong and so untrue. And I think that's where so many of my colleagues, and I think that's what Dr. Murphy was expressing here. It's just an enraging notion, and it's something that I think is just harming medicine in a terrible, terrible way.
I will just say this, this is, all of this discussion is not to say there's not racism in the world. There's not. I mean, there are people who are that way, but to imply and infer and indict a certain part of the medical profession and the academic world because of that small minority and say that they're treating any different is blatantly wrong. Blatantly wrong. And I will tell you, I appreciate so much your efforts, Christina, all the work that y'all do to continue to fight this nonsense.
Well, I'll just end on one upbeat note that recently I had a reason to review the data on patient preferences, and thank goodness the vast majority of minorities, they don't care who treats them,
Yes,
as long as they're
exactly.
competent, and they care about them, and they're in their payment plan. But so that was reassuring because it really undermines so much of the message that.
And the study that said it did, the author left out data to prove a point. And that's all been exposed.
Is that the Oakland study or the
I'm not
the
exactly, I'm
baby
trying to
study?
remember exactly which one that was, but that was the one that AAMC was citing and
I
everything.
think that was the baby study.
Absolute,
Yeah, the baby study.
absolute farce.
Yeah, actually, Senator
Jackson.
Ketanji Brown Jackson. I don't blame her. I don't expect her to read the literature on this carefully, but she
That was,
actually
that
put
was, yeah, that was a study where she said that during the case that Black babies had a 50% survival compared to white babies, vice versa, white babies 50% greater survival than Black babies if they weren't treated by a Black neonatologist. Well, it turns out they were comparing apples to oranges. The Black babies were not actually were cared for specialists. Most of the specialists turned out to be white because they were a very low birth weight. They had a cutoff for birth weight at 1,500 grams, but the Black babies were down to like 1,000 or 1,100 grams, and they had such a high risk of death anyway that it was impossible to attribute it to the doctors who were taking care of them. And yet that was excluded from a discussion of the case, and that was excluded from the paper itself, that discrepancy between the birth weights, and the whole thing just turned out to be a lie, yet it ends up in the Supreme Court as a comment by an important, American jurist. So it was just awful.
Yeah.
And it got perpetuated, and you'll still read it, and you'll still see it, and it'll still be referred to, and it's just wrong. Absolutely wrong.
All right. Well, again, thanks everyone for coming. Thank you, Representative and
Thank you so
Dr.
much.
Goldfarb.
It's great. It's so good to see you. Good to see you. Yeah. I have a cranial pharyngioma.